Hi everybody, this is Katie Liebenstein again. So now I'm going to go through the hepatitis C screening and treatment decision tree, which was sent out to everybody. If you didn't get a copy, please let me know and I can send that along. I'm going to go through this and hopefully answer any questions that there are about this. So just to point out from the beginning, anything here in yellow, as you can see here in the key, are steps that are going to be completed by you as the patient's primary care provider. And anything in blue here or teal are going to be steps completed by myself or any of the staff here at Santa Fe Community Guidance Center. Okay, so to start with, to kind of reiterate, we want to screen all patients who have not previously been screened or any patients with ongoing risk factors for hepatitis infection. So we kind of move over here, how are we going to do this screening? And this is a new thing. In addition to your normal labs, so ordering a CBC and CMP and anything else you would order, you're also now going to be able to just order what's called HCV screen, and that's going to be on the pick list here pretty soon, probably in the next month or so. And when you click this, it's going to order things like a hepatitis B profile, hepatitis A antibodies, hepatitis C antibodies, and viral load and genotype, all of which will not be charged to the patient unless the patient truly does have a hepatitis C infection. Those tests are kind of like reflex tests that will only happen if the patient truly comes up positive for hepatitis C antibodies. Of course, any patient who has been infected in the past and either cleared the infection on their own or treated in the past, they're always going to come up positive for hepatitis C antibody, but will have no viral load. So that brings us to what happens with our results. So if we go up from here, we have a patient with an undetected HCV RNA and a reflex genotype is credited. And you'll see this in your labs from Tricor or wherever you get your labs. So whether or not they have an antibody positive, if you see an undetected RNA and no genotype, that means they do not currently have a chronic infection. So if they have any of those ongoing risk factors we talked about, they need to be rescreened every 12 months. If they have no ongoing risk factors, then screening is completed. Okay, so for the patients who come up positive, what you're going to see is an HCV RNA level. This can be anywhere from a few thousand to many million copies of the virus. And you'll also get back a genotype. And sometimes these labs take a little bit of time, so you can be patient a little bit with these. The genotypes often take quite a few days longer than the RNA levels, sometimes up to a week. So now your job after this is to discuss with the patient the HCV diagnosis. With my patients and my patient population, a lot of them, especially in the IV drug use community, already know that they have hepatitis C, so this is not necessarily any news to them. But for other patients, this can be kind of shocking. So I want you as the primary care provider to have that discussion with the patient and at the same time to reconcile the patient medication list. This is very important because of potential interactions that are going to occur with the medications that they're going to be put on for hepatitis C. So I really need to know what they are truly taking and what they're not. And at the same visit, it would be great if you could start vaccinations for them. So if they need hepatitis B vaccinations, so for example, if they do not have any surface antibody to hepatitis B or hepatitis A, they need to get started on those series. And then also these patients with liver disease really should have a pneumonia 23 shot and a flu shot if we are in flu season. So the next thing that's going to happen, and actually this can happen once you get those labs confirming a positive patient, is to task me from that patient's chart that this person has hepatitis C and needs to be seen through telehealth. And then you'll have your MA schedule that person with me, or the lead MA actually at the distant site, however we decide to do it at your specific site. We'll then schedule that person with me for an initial telehealth visit. Currently, I'm seeing those patients in my schedule on Wednesday mornings from 9 to 12, and we can discuss with the MAs further on how to schedule those so that it's clear. So then at that point, I will have that initial telehealth visit, and that's where I'm going to talk with the patient about the process and really figure out if they're appropriate for treatment or not. So that's where we're going to see here there's a possibility of a decision to defer treatment. So a good example of this is a patient with severe or moderate alcohol use disorder who I think maybe needs to work on sobriety or at least work on stability before they can be treated. Certainly drinking alcohol is not a contraindication for treatment, but a patient who I'm concerned may relapse or who may not be stable enough to take a full course of medication is not a good candidate for treatment. And with those patients, we're going to create a plan for ongoing testing or diagnostic studies that I would then send along to you as the primary care provider. The majority of the patients, though, I will decide to treat because most of the patients are good candidates for treatment. And so once I decide to treat, I will submit to the patient's MCO for a prior authorization for their medication. The patient will be notified when the medication has been approved, and then the patient should receive the medication in the mail via FedEx or UPS through a specialty pharmacy. And the patient will have also been told that prior to starting, they'll need to see me for an initial telehealth visit. On a case-by-case basis, some of these I may just do over the phone, touching base with patients. They will also be seen at 4 weeks, 8 weeks, and 12 weeks if their treatment is that long. Some patients will actually have treatment for 16 weeks, in which case they would be seen at 16 weeks as well. And each one of these visits does include a lab draw, so they'll need to actually come in for telehealth visit and have their lab drawn at your site. Okay? And then lastly, at 3 months post-treatment, we do one more RNA level, and as long as that's 0, then that person is in sustained virologic response and has been treated. And then we come back to, should we screen them again? So if no ongoing risk factors, nothing else is needed. If they do have any of those risk factors we discussed, they need to be rescreened every 12 months. So I do want to say as a disclaimer, this is a new program we're going to be doing. There are going to be some bumps along the way. So if you have any recommendations for me, or if you have any questions about the information I've presented or this treatment decision tree, please reach out to me. I have provided on the background sheet that I sent out to everybody my email address and my cell phone number, and feel free to contact me with either of those. I would appreciate it if you did not share my cell phone number with your patients with hepatitis C. And I look forward to working with you all, and hopefully we'll do a lot of treatment of hepatitis C here in the coming months.